We move to the next session. It is again a viewpoint. Management of atrial fibrillation. This is a very old story. Whether the rate control is the logical solutions to deal with it, we have Dr. Dipankar Ghosh Dastidar, and whether the rhythm control should be tried in the majority, to speak on it, we have Robin Chakraborty. To chair the session, we have Dr. H.K. Chopra, Dr. Dhiman Kahali, and Dr. Devanu Ghosh. Over to you.
Thank you very much, Santanu. I think it's really an honor for us to chair this session along with my colleagues, Dr. Dhiman Kahali and Dr. Devanu Ghosh. The previous debate or the point of view was brilliant, and I'm sure this point of view also should be as brilliant as it was last time. And I think this is, as mentioned by Santanu, this is again like a old wine in a new bottle. We talk of point of view, which is a very, very old debate, rate versus rhythm. And we have two speakers, Dipankar Ghosh and Robin Chakraborty. One is talking on rate, another on rhythm control. Let's see what is new, what is the outcome data, and what is the mortality data. I welcome my colleagues, Dr. Dhiman Kahali and Dr. Devanu Ghosh, to make any comments before we start the session.
So I think without losing any time, both the speakers are very versatile speakers, and let us listen from the horse's mouth what new points they tell to the old subject.
Good evening, sir. Thank you, Professor Guho, for giving me the opportunity to speak in this August platform. Now, I will be talking on rate control is a logical solution in atrial fibrillation. Next slide, please. At the outset, I must say that we are dealing with four types of AF. One is the paroxysmal, one is persistent, one is long-term persistent, and one is permanent. Now, in permanent, one has already decided on a rate control strategy. So the dilemma is whether you want to treat the other three variants with a rate control strategy or you want to go for a rhythm control strategy. The particular dilemma is between long persistent AF versus whether you want to consider is a long persistent AF and give antiarrhythmic drugs, or you want to consider them as permanent AF and give rate controlling drugs. Now, one must remember these facts about AF. Now, AF is a sustained arrhythmia. So once a patient is on AF, AF tends to recur, AF begets AF. And there is a high rate of recurrence, and patients often have undiagnosed paroxysms of AF, even if their baseline ECG shows to be sinus. Next slide. Now, the limitations of rhythm control strategy. One is that limited efficacy. Most patients, even on antiarrhythmic drugs, they continue to have AF. And then there are the adverse effects of antiarrhythmic drugs. Most antiarrhythmic drugs are proarrhythmics by themselves. And even after a rhythm control has been achieved, there are chances of AF recurrence with fast ventricular rate when rate control is needed. Next slide, please. Now, I'm just quoting this from the systemic review on antiarrhythmics for maintaining sinus rhythm after cardioversion of AF. And this is pretty recent, from 2019. Now, overall, there is evidence showing that antiarrhythmic drugs increase adverse events, increase proarrhythmic events, and some antiarrhythmic may increase mortality. Conversely, although they reduce recurrences of atrial fibrillation, there is no evidence of any benefit on other clinical outcomes compared with placebo or no treatment. Now, this statement has come from this Cochrane database systemic review. Next slide, please. Now, I go back to this age-old trial, the Afm trial, which tried these two strategies. They compared the rate control versus rhythm control. And you can see that as the years pass by, the curves tend to diverge from each other, with rate control showing lower evidence of cumulative mortality. Now, it is quite obvious that if you keep a patient on a prolonged antiarrhythmic agents, their proarrhythmic effects possibly are increasing mortality. Also, there is no issue of difference between anticoagulation between the two strategies. So in the long term, if you see that if you keep the patient on rhythm control, it is better to keep them on rate control. So for the mortality is concerned. Next slide, please. Now, Another trial, the RACE trial, also is showing similar results. And as years pass by, you see the two curves to diverge from each other, with rate control showing higher survival probability than a rhythm control strategy. Next slide, please. Now, an important asset of rhythm control is catheter ablation of AF. But unfortunately, 50% patients have detectable AF after 1 year post-ablation. And there is poor success rate in long-standing persistent AF. 4% risk of major complications, and risk of dying within 30 days post-ablation is 1 in 1,000. So as we talk about AF ablation as a rhythm control strategy, it has its inherent disadvantages. So one must take these in mind before advocating this form of therapy to any patient of AF. Next slide, please. Now, this study will show you that as the age increases, both in male and female, the prevalence of AF increases. So two things one must consider. One is that if you start a patient on an antiarrhythmic drug at a young age, you have to continue that drug lifelong. The other point is that elderly population are more prone to have AF. Also, elderly populations are more prone to have the side effects of antiarrhythmic drugs. So in this population, whether you want to use the antiarrhythmic drugs, or even in young population, whether you want to start on antiarrhythmic drugs and continue on a prolonged course. So these are the two dilemmas you have to face. A better strategy, of course, would be to keep them on rate control and continue their management. Next slide, please. So as I was talking of, the very elderly make up 35% of patients with AF. And AF in this subgroup is often permanent and highly sensitive to the pro-arrhythmic effects of antiarrhythmic drugs. Next slide, please. Two things you have advantage in rate control strategy. One is that you gain hemodynamic stability, because if you just control the rate, most patients remain hemodynamically stable. And that way you can also avoid tachycardia-induced cardiomyopathy just by simple rate control. Next slide, please. Now this Afm trial, they used either beta blocker, calcium channel blocker, or digitalis, or their combination. Whatever be their combination, almost 80%, to the tune of 80% of the patients did well with rate control. Next slide, please. Thus, pharmacological therapy can achieve adequate rate control in approximately 80% of patients. Next slide. Race 2 investigators tried whether lenient rate control versus strict rate control was useful. Now, by lenient rate control, you can keep a heart rate around 110 beats per minute. And with strict control, you have to bring down the heart rate at 80 beats per minute. They didn't find any big difference in either the primary or the secondary outcome in a follow-up of 2 years. Next slide, please. So you can effectively carry on lenient rate control even in patients who have less than 110 beats per minute. In that way, you can give less medication, so you will have less adverse effects, less cost, and fewer OPD visits. One caveat is that with patients with LV dysfunction and the patients who are in heart failure. Now, patients in heart failure, they need a stricter rate control. And there is a lot of controversy whether beta blockers are good drugs in patients who have LV dysfunction as well as atrial fibrillation. Now, we routinely use beta blockers in patients with LV dysfunction. Rather, I should put that they are the #1 drugs to be used in patients with LV dysfunction. So no wonder they are also effective in this group in LV dysfunction with AF. Vis-a-vis, if you compare with rhythm controlling drugs and antiarrhythmic drugs, they have their side effects. So long-term AF burden, which no trial has put it at its endpoint, AF burden, that remains to be tested, whether definitely there is any advantage of using antiarrhythmic drugs in patients with LV dysfunction, or rather you can just keep on them on beta blockers with AF with LV dysfunction. Of course, digitalis you can add, but you must avoid the calcium channel blockers if LV dysfunction is there. Next slide, please. So this is the management algorithm, mainly beta blockers, calcium channel blockers, and digitalis. Now, if that fails to achieve adequate rate control, people may consider AV node ablation with some form of pacing. Next slide, please. So this is just a nutshell of what I was telling, the three groups of drugs for rate control. Next slide, please. For acute rate control, one can use short-acting IV beta blockers like esmolol. IV calcium channel blockers can also be used, but we tend to commonly use IV amiodarone for acute rate control. Next slide, please. Now, these are the rate controlling agents. In heart failure, calcium channel blockers need to be avoided, and a combination of beta blockers and digitalis is the best in heart failure. Next slide, please. Now, the caveat of using IV amiodarone, which is an antiarrhythmic drug, in acute phases is that one must rule out that the patient doesn't have an accessory pathway, because there are case reports of using IV amiodarone and AF generating into VF through transmission into the accessory pathway is there. Next slide, please. So this is one precaution one must take, because IV amiodarone, until conversion to ethyl amiodarone, acts predominantly as a beta receptor antagonist, and as such have the beta blocking agent, beta blocking effects on the AV node. So this is one caveat one must keep in mind. Next slide, please. So chronic rate control. So rate control target ideally should be less than 85 beats per minute, but lenient rate control target is also allowed, 110 beats per minute, and the agents I've already discussed. Next slide, please. So AV node ablation, this can be useful rate control strategy, and AV node ablation was acutely successful in 97.4% of patients. Only 3.5% had recurrence of AV node conduction. Next slide, please. So this ablate and pace trial, they showed that majority of the patients after AV, they underwent successful AV node ablation, and some form of pacing was done. Next slide, please. So if there is LV dysfunction, so one can do AV node ablation and put the patient in a CRT. Otherwise, AV node ablation with VVI can also be tried. Next slide, please. So rhythm control is elegant in concept but difficult to achieve. That's one point one must keep in mind. Rhythm control does not obviate the need for anticoagulation. Next slide, please. Next slide, please. Next slide, Jignesh.
So we've received only till this, sir.
Pardon?
Sorry, nice slides.
Bottom line message is that, forget it. Bottom line message is that rate control is an effective strategy. It does not use a lot of medications, and there are a lot of patients who are kept on initially who have tried rhythm control strategy, and after trying various strategies of these drugs, they have failed and they have come back to rate control. So ultimately, patients do remain well on rate control, as statistics are showing. There are trials to back up my statement. So rate control is a logical solution for management of AF, particularly cases of long persistent AF. You may consider them to be having permanent AF and keep them on rate control. Thank you, sir.
Thank you, Dipankar. Elegant lecture. Very nice lecture. I enjoyed it a lot. And it's an old debate. So it's true that Afm Trial also told that there is no difference in the outcome between the rate control and the rhythm control strategy. And the difference is because of the drugs, because the drugs have got some side effects, and that increases the morbidity and the mortality. So with